everyone, to this RBMO live webinar hosted by I3, the International IVF Initiative. Today, we focus on the latest developments in vitrification and warming of human oocytes and embryos. My name is Mina Alikani, and I'm delighted to be joined by my co-host, Dr. Başak Balaban, who kindly accepted this invitation to stay up very late in Istanbul to co-host this webinar. Başak heads the IVF lab at the American Hospital in Turkey, where she has practiced since 1996. She is a past president of Alpha Scientists in Reproductive Medicine, a former executive committee member of ESHRE, and of course, one of our clinical embryology section editors at RBMO, where she plays an important role in the review and selection of papers that we publish. Thank you, Başak, for being here. I've had the honor and privilege of being involved with RBMO as a section editor starting in 2010, and then as editor starting in 2015. And since 2022, under the leadership of Professors Nick Macklin and Juan Garcia Velasco as co-chief editors. Over these many years, I've watched the journal that was founded, nurtured, and loved by Bob Edwards evolve and grow while staying true to a vision that was eloquently stated by Nick Macklin as publication of high-quality discovery science that challenges orthodoxy in human reproduction. The very interesting story of the founding and evolution of RBMO is delightfully retold in a recent paper by Kamal Ahuja and Simon Brown, and I encourage you to read it. I have another connection to RBMO, and that is through Alpha Scientists in Reproductive Medicine, where I have been president since 2022. RBMO is our official journal, which is freely available to our members and where abstracts of our biennial conferences are published. So, if your abstract to our 2026 meeting in Dubrovnik is accepted, you can expect it to be published online in RBMO. And that was my subtle plug for Alpha and the 2026 conference in Dubrovnik. Let me now turn to this session and introduce the hot topic of discussion today. This audience is, of course, well aware that vitrification and warming are integral to current practice of assisted reproduction, and this cannot be overstated. For years, we have operated on the principle that to be successful, vitrification and post-warming dilutions must be done stepwise, each step with a defined exposure time. But this concept is challenged by data, some dating back decades, albeit in other mammalian species, showing that protocols can be completed faster, reducing multiple steps to 1 or 2 steps, and replacing multi-minute exposures with shorter ones. The modified protocols do many things. They reduce the time of exposure to suboptimal temperature and osmolarity conditions, minimize exposure to potentially toxic cryoprotectants, improve workflow in the laboratory, but also, as we will hear today, may lead to other improvements. As with any modification to established technologies applied to human gametes and embryos, rigorous validation across different laboratories is essential before universal adoption. And the 3 papers from prominent groups presenting today speak directly to this need. Having had the opportunity and the pleasure to see all three papers, today's three papers, through the review process as the handling editor, I can tell you that one issue that was front and center in all three was terminology. In this context, fast and ultra fast and furious do not refer to faster cooling or warming rates. Those rates are unchanged. They refer to shorter duration of the dehydration and post-warming dilution steps. And hopefully we'll have a chance to unpack this further after the lectures. I would also like to mention that RBMO has published other papers in this series, including an insightful and thought-provoking commentary by Michiri entitled Fast to Fastest, Single-Step Sucrose Dilution to Direct Hydration of Vitrified Warmed Human Blastocysts, where he argues that, quote, we may yet see warming protocols that forego elution in non-permeable solutes in favor of an even faster method, rehydration directly in culture medium, end quote. I highly recommend this and the other recent RBMO papers on the topic of today's webinar for further reading. I'd like to remind you before introducing our first speaker that to please post your questions to the Q&A section of the platform and not in the chat section, so they can be picked up by our team and discussed at the end of the last lecture. Now it's my pleasure to introduce our first speaker, Dr. Lodovico Parmegiani. Lodo, as we call him, is the head of embryology for Next Clinics International, a network of art centers in Europe. He's also IVF laboratory director at the Next Fertility Gynopro in Bologna, Italy, and an advisor to several biotech companies. He has invented, developed, and optimized devices and methods for human clinical embryology and published almost 100 papers and book chapters in this field. He's an editor, a TED speaker, and a key opinion leader in assisted reproduction. And today he's going to present his recent RBMO paper focused on the universal warming protocol for human vitrified blastocysts. It's a pleasure to see you here. Happy birthday, by the way, and the floor is yours, Lodi.
Thank you very much, Mina. It's a great pleasure for me to be here, and I don't have the words, okay, because I remember when I made the first presentation for I3. It was the first was during COVID period. And now I'm here again, and particularly in this section for RBMO, which is one of my favorite journal. So I would like to go straight to the topic, which, as usually, everything, it starts with a need. So in Italy, we were focused on oocyte cryopreservation, particularly from 2004, because weird, strange law obliged us to inject only 3 oocytes and cryopreserve the other oocytes. So we were using oocyte slow freezing, and then we were reading and looking at all the novelties in this field. And then I remember, of course, all the in that period that we were very curious about the articles from Gabor Vaita and Masa Kuwayama, Pierre van der Zwarmen, Safa Alassani, just to name some authors in Europe regarding vitrification. And so after 20 years, we are here, and it seems that we have another acceleration in these protocols. So if we consider the need at that time was that we were switching between the slow freezing and vitrification. And then after we made this switch, the first adopters of vitrification, they were making by themselves the vitrification kits, the solution. And then in that period also, all the problem related to quality management arises. And then we were, also, I must say, obliged to use ready-to-use kits that were certified, particularly in Europe, with CE medical device certification. And at that time, we already had slow frozen oocytes, embryos, and we already had the vitrified oocytes, embryos that were vitrified with our in-house solution. I don't want to bore you, but this is how the story, how the whole story started. So if we consider that nowadays reproductive cells are cryopreserved with various protocols, if we consider vitrification and we look at extraction for use in the different brands, we see different protocols, but mainly they are differing from the size, so the volume of the droplets. And then, of course, by the non-permeant solutes. But at the end of the day, the final goal is to obtain the glassy state, which was the same final goal of the slow freezing protocols. So, considering then that oocytes and embryos are vitrified and warmed using different brands or ready-to-use kits nowadays, with these protocols that just vary for timing and volume of the droplets, having a universal warming protocol may potentially simplify the lab workflow and facilitate vitrified reproductive cell tissue exchange between assisted reproductive centers. This is what I was thinking since the beginning. So since 2008, 2009. With our group, we took this proof of concept study, which was the seed of the concept of universal warming. And that time we had some patients that they donated their slow frozen oocytes for research. So this was a study performed on sibling oocytes. And sibling oocytes that were slow frozen, we said, okay, if we are able to demonstrate that just using 1 molar sucrose at that time, or trialose, so I mean, the same protocol that we were using for vitrified cell to warm slow frozen oocytes, which is the most sensitive human cell to cryoinjury, we can hypothesize that this can be a universal protocol. But this is because when we were talking with embryologists working in the veterinary field, they were doing this using just 1 molar sucrose. So we did the study, and surprisingly, we observed a comparable survival, which was 90%. So a better trend also when warming these slow frozen oocytes. And also what we did, we activated these oocytes to do parthenogenesis, and we observed the same developmental competence. So the conclusion was that this could be a procedure, I mean, using 1 molar sucrose and then some dilution in that case, to warm any reproductive cell tissue irrespective of the freezing protocols. Then in that period, we wrote several abstracts by studying also the spindles of these oocytes, but I would like to go straight to the clinical application, the real clinical application of this idea, which is which started some years after when we started to consider that it was possible to demonstrate that we can combine the different vitrification and warming kits. This because, since we were making by ourselves the vitrification solution, it was very strange to see that in that case, some companies were saying to the customers that it was possible to warm the blastocysts or oocytes only using the respective warming kit of the product they use for vitrification. Of course, this is, we have to split this need and this declaration of manufacturer, because this is something that it is the only way that they can write in the instruction for use for the real world. From the real world. So if we consider the studies that we have performed, this, for example, was a study published in 2017, in which this was a strict prospective randomized study, in which we tried for the first time to clinical apply the concept of a universal protocol by combining different kits. So in this case, we studied blastocysts. There were more than 800 blastocysts. There were vitrified with kit azato and then warm kit azato kit, or vitrified with kit azato and warm with sage Cooper surgical kit, or vitrified with sage Cooper surgical and warm with kit azato, and then sage. And we did not observe any difference in survival implantation rate. Then we published a second clinical study. This was on cleavage stage embryos, more than 1,000, in which we also studied another group of embryos that were vitrified or warmed with in-house homemade solution, in this case with PBS. Then we also tested this protocol with oocytes. This was in 2018. In this case, more than 800 oocytes were vitrified with kit azato and then warmed with kit azato or with Irvine Fujifilm. This is also curious because, again, we did not observe any difference in fertilization of these oocytes, blastulation, and implantation rate. This was curious because this study was performed in the same period in which in Europe for a time frame in which kit azato kits they had lost the CE mark. So for some months in Italy were so scared in using this commercial kit without the CE mark. And then again, what we said, okay, this is working in our hands. Let's see if this can work also in other hands. And we did this multi-center study in which the oocytes were vitrified in Spain, almost 2,000 oocytes. And then these were warmed into two different centers in Italy. And also in this case, the oocytes were vitrified with kit azato and then warmed with kit azato or Irvine. And also in this case, we did not observe any difference in survival, blastulation, implantation, live birth rates, or was comparable. So considering these studies, we combined different kits that were based on different basic medium with 190.99, which is, in some kits such as kit azato or also Cryotech, and then with the HTF MOPS, PBS, HAMS, with different non-permeating solutes such as trehalose or sucrose, and different supplementation, so hydroxypropyl cellulose, dextrose serum supplement, or albumin. Basically, we kept stable the volume, which was 4 milliliters at the time of 1 molar solution on non-permeating solids, so trehalose or sucrose at 37 degrees Celsius. And then if you see these articles, we have different dilution, basically always the 0.5 second step, and then some difference in the washing steps. So I would say that that period wasn't so easy for me, because anytime I was submitting these articles, the editors and the reviewers were saying that this was not interesting, not probably something not justified. But what we would like to do in that period, it was just to create a literature. So create, to give us support for embryologists that were already doing this in their lab. So I'm pretty sure that the majority of the auditors of this webinar, they can say, oh, we made this combination. We know that it is possible to have this interchangeability between kits. But what we need to have this off-label use of the kits, we need to have a literature, because this can protect us. So this was the main reason that pushed me and my group to make these studies on the combination of kits. So, and I was very happy when I was invited by other groups to work together with them in similar studies, or when I was involved as a reviewer and reading these articles that were inspired by our studies, such as this for example, this is testing on blastocyst, the universal warming, and testing the interchangeability between kitazoto, irvine, and sage. In this case, we got kitazoto, irvine, kitazoto with vitrified omnia, 1 molar sucrose. Again, vitrified omnia, 1 molar sucrose with kitazoto. So I was very happy, because our results with 1 molar non-permeant solutes supported the off-label use of different combination of vitrification and warming kits, allowing my colleagues for a while to come out of the closet. So, and then we come to the second wave, the second reason why we decided to publish our data of the last year regarding the universal warming, the combination of different kits. So when I started to see, we started to read the possibility to take out some washing steps, particularly after the inspiring articles from Juergen, and it's an honor for me to share this webinar with him, and of course with Anna. So we started to understand that since the little difference between the protocols was based basically on the volume and following step after the first dilution step, so using this protocol with a single step, just a single step of warming, was making the universal protocol more universal. And so this probably was the final step to do. So this was the inspiration for the latest and largest clinical study that it is published on universal warming. So it's an honor for me to that this article is published on RBMO Online. So with this article, the idea is to definitely give an answer to this question. So it is possible to have an efficient protocol when combining different brands of vitrification and warming kits, also when reducing warming droplets volume, because I guess that you can read the instruction for use, and your instruction for use can say, of your favorite brand can say 4 milliliters of warming of TS, and you are using one ml, and you say, okay, it's working perfectly. Some others are working 0.5, and they say, oh, this is perfect. I'm the best because I'm not spending a lot of money. In some other case, the same solution in different brands, it is suggested to use 0.5. So we all know, we are embryologists, and we all know that probably this is only due to the instruction they use for certification. But we know that we can use it in different way, of course, according to our standard operative procedures that we have to write based on our experience, based also on our validation that we do in our laboratory. And then, okay, also, what about by using just a single rehydration step? So to do this, the article that we published on RBMO Online is based on 2 core studies on more than 3,000 vitrified and warm blastocysts. In the first study, study number 1, we observed the combination of different kits. You will see how many groups we had. By using the conventional warming with 4 milliliters of volume, because we love to be comfortable and use a lot of volume. Also with kits that commercial kits that are not suggesting to use 4 milliliters. And then in the second study, we decided to change a little bit to study a group in which the TS solution, so the 1 molar non-permeating solid, was also 0.5. And other groups in which we totally took out the 0.5 step and the washing procedure. So using the single step warming, completing the universal warming in the universal single step warming. So results the same. Cryosurvival, clinical pregnancy rate, embryo implantation rates were comparable between all the groups in both studies. And then for the first studies, we also had a live birth rate and neonatal outcome, which were comparable between the groups. So this table is because probably you already read the article, or you can go to read this article. And this is just to highlight that we had all these group compare, so chitozato with chitozato, chitozato with sage, chitozato with irvine, sage with chitozato, sage with sage, sage with irvine, irvine with chitozato, irvine with sage, irvine, our in-house with PBS in chitozato, in-house with sage, and in-house with irvine, with no difference in survival, clinical pregnancy, implantation, and live birth. So we had, all this baby born. And this was the second study. In the second study, as I told you, we introduced the single step as described by Juergen. So just a step in 1 molar sucrose or trehalose, and then quick rinsing in the basic medium and then in the culture. Also, in this study, we did not observe any difference between the different groups. In this case, we warmed with irvine. Here we warmed single step with irvine, single step with chitozato, single step with sage, single step with another brand, which is Vita Vitro, a Chinese medium. So this was to demonstrate that at the end of the day, it was possible to obtain the same results with any kit. So the article is concluded. So just to conclude is that in the meantime, we're writing this article and publishing this article, there were other groups working in the single step, okay? So we have this excellent article from the group from Saloniki, with more than 1,000 blastocysts. They split the two groups in conventional single-step warming. They used Irvine. In this case, of course, Anna, she will describe their experience with oocytes, with Kitazato. And of course, we got these articles on more than 1,200 healthy infants born after the one-step warming of blastocyst. So considering this, we proceed further in order to continue the universal single-step study. In this case, this was a study which was published, which was presented at ESHRE meeting in Paris. In this case, this is all single-step. We compared Sage and Sage, Kitazato and Kitazato, Kitazato and Sage, Irvine, Irvine, Irvine and Sage. The results were comparable in terms of survival and pregnancy. And this is another study that it is submitted, which was performed in China. And in this case also, we had a comparable survival rate. In this case, we compared Kitazato and Vitavitro. So the conclusion, it is possible to combine various kits for vitrification and warming. The universal warming by using 1 molar of sucrose or trehalose can be efficient when reducing the volume of the first warming solution because we obtain the same results. It is possible also to take out the 0.5 step and the washing step with any warming kit, with any brand. So what I don't want to see companies saying this is better than the other, because I can't believe this, and I've demonstrated this. We have demonstrated this. So the universal single-step warming is a very promising variation of the universal warming, which will contribute to a streamlined lab workflow. It will help us to reduce costs and favor the exchange of reproductive cells between IVF centers. It will allow us to permit a quick and efficient warming of vitrified specimens, irrespective of brand, dry protectants, and basic medium in the vitrification kit. And this is the wider implication of this protocol. I had the pleasure, and again, this was published on RBMO line, to apply this protocol also on ovarian tissue, on ovarian slow frozen tissue. And just using 1 mole of sucrose allowed us to obtain excellent results also on ovarian tissue. So what's next? Of course, this can be the subject and the topic for another webinar. Maybe it is, of course, the shortened vitrification protocol, which you know that it is the second gem that we have. The first gem that we need just to polish was the single-step warming, then this shortened protocol for vitrification. So just 1 minute in equilibration solution and 1 minute in vitrification solution. Just to give an anticipation, just for this webinar, this is our study on universal shortened protocols for vitrification and warming. So this is the first time that I show this this data. Of course, in this case, we performed ultra, so the ultra rapid protocol of vitrification and single-step warming with Irvine, Kitazato, Vitavitro, Sage, with the same survival rate. And I don't tell you the results within the group because this will be published and in the future. It is submitted to a very important congress. If not accepted, you will see in another congress. And I'm waiting for the first baby to born next week. Thank you for your attention.
Thank you very much for this excellent lecture, dear Lodo. It's a pleasure to see you together with us tonight. And before I ask a question to Lodo, I'd like to welcome everyone to today's webinar. And I'd like to thank Mina for her nice and kind introduction at the beginning. It's a privilege and honor to co-host this webinar together with her. Lodo, this is actually very encouraging to see that universal single-step warming can work efficiently for blastocysts with various brands of vitrification and warming media. This is actually a very critical issue, practical critical issue for countries where the patients very often, carry their embryos from one center to the other. So it's very important to see these efficient results. So my question would be a very general one, actually. Have you experienced any data with cleavage stage embryos, or more importantly, with oocytes retrieved from infertile patients with the similar protocol?
Yes, with oocytes, for infertile patient, yes, we got data, but small data, because now in Italy we are not freezing a lot of oocytes. For sure, we are warming some oocytes, and now we are, when you started this thing 20 years ago, and now you quickly understand that this protocol is working. It is working well. It is working well also with oocytes, but I don't have data. This is not my duty, I think, because there will be big groups that sooner or later will demonstrate this. I'm sure. It's the first time that in my life that I'm sure about something in this field.
Okay, thank you. We'll have the other questions at the Q&A section. I thank you very much again for your nice lecture.
It's a pleasure.
Thank you.
It's a pleasure.
So it's now my great pleasure to introduce the second distinguished speaker, Dr. Anna Cobo, who obtained her PhD in 2008 from the University of Valencia. And she has worked as an embryologist for 30 years. And her main area of expertise since 1990s is oocyte vitrification. And we all do follow her extensive publications, as we all know. She's currently a senior embryologist at EVRMA Valencia, Spain, where she is the responsible person for cryobiology unit. I also had the pleasure and privilege to work with her at the Alpha Executive Committee during the time when I was the chair of the society. So welcome, my dear friend, Anna. So the stage is yours for your presentation.
So, okay, thank you. I'd like to thank the organizers for inviting me to join this webinar. And it's also a nice chance to reconnect and see some old friends and colleagues. And it's also a very nice opportunity to discuss about the recently modified protocols for vitrification. Next, please. So we all know that vitrification has been a breakthrough in assisted reproduction technology, but of course, we also know that it has some main drawbacks. And I would say that the main problem is the toxicity that is a potential problem of using highly concentrated cryoprotectant solutions that can cause damage to cell membranes, proteins, and organelles. Several attempts to solve these problems have been made in the past, as the use of a cryoprotectant mixture Go back, please. The use of ethylene glycol and DMSO is the most common mixture. We can also decrease the cryoprotectant concentration by increasing the cooling rate. And this was shown by Roller and Fahey back in 1985. If we increase the cooling rate, then we can allow us to use lower cryoprotectant concentration, as you can see in the image at the right. And the third option is, of course, to reduce the exposure to cryoprotectant. Next slide, please. And I think the work, the paper published by Gallardo and co-workers in 2019 has been like has opened the door to the update and the modification of the vitrification protocols as we have known them until now. So basically, and very briefly, what they observed in the in silico simulations was that, as you can see in the upper image, after 1 minute in the non-vitrifying solution, we know this solution as equilibration solution, the osmolarity in the cell was exactly the same that after 10 minutes in this solution. So there is no increase in the tendency of glass formation. So at this point, it is pointless to prolong the exposure to the cryoprotectants because of the potential toxic effects. Next, please. These are other simulations that were lately published by my colleague Miguel Gallardo as well in the Nuno Costa Borges study in the human reproduction. And it shows the simulations for the osmotic behavior, the changes in volume of the oocytes by using different combinations of these modified protocols. So in the first image, we can see the osmotic behavior in the when we use the standard vitrification and the standard warming procedure. The second figure shows the changes in the cell when we use the standard vitrification, but we use the fast warming, or more correctly said, the one-step warming dilution procedure. At this point, as you can see in the upper part of this figure, there is a risk of swelling when we warm, according to these models, of course, when we warm rapidly a cell that was vitrified by the standard procedure. And in the third figure, we can see the osmotic behavior of the oocyte when we apply the shortened protocols for both vitrification and warming. Next. So this is the conventional protocol, as we have known them. We've been using it for almost 20 years. So it is a first equilibration procedure, which takes from 12 to 15 minutes, and it's followed by 1 minute in the vitrification solution, and then direct immersion into liquid nitrogen. And for the conventional warming is a step-wise dilution of the cryoprotectant. So the first step would be 1 minute, 37 degrees Celsius in the hyperosmolar solution, the osmotic solution, which is we regularly use trehalose or sucrose. And then there is a dilution, an additional dilution step in a half concentrated solutions using the same sugar, and it's followed by 2 washing procedures of 5 and 1 minute. This is what we have been done from, as I just said, almost 20 years. Next. Next. So this is not like this anymore for the vitrification. We are shortening the equilibration procedure. Next. So now what we do is just 1 minute in equilibration, and then 1 minute in vitrification and direct immersion in liquid nitrogen, and for warming, next. So there is no longer stepwise dilution. Next. What we do now is just the first step in 1 minute in the what it is called thawing solution, wrongly called thawing solution, and then directly to the culture dish with the culture media that we regularly use. Next. This is a very nice study that was published by Cho and co-workers. This was using the animal model with mouse oocytes. And it shows the osmotic changes in these oocytes, and in the you can see the pictures. Next. So with the shortened protocol for vitrification, what we can see is a contraction and contraction of the cells. So contraction, once we submerge the oocyte into the equilibration solution, and then additional contraction in the vitrification solution. And this is also shown in the curves in the blue line, as you can see here. Next. And for the conventional vitrification protocol, what we have is an initial contraction in the equilibration solution, and then we allow the cell to regain liquid. So there is an expansion, and then there is a contraction again when we put the oocyte in the vitrification solution. This is also shown in the orange curve in the down part of the slide. Next. So the amplitude of the cell contraction and expansion can cause significant volume changes that can lead to osmotic stress and can alter the distribution of the organelles. Next. As just mentioned, the large or the prolonged exposure to the cryoprotectants can result in higher toxicity and can damage the cellular organelles. Next. And of course, to reduce the exposure to this solution can allow a better conservation of the cell. And actually, next, these authors observed this by studying the endoplasmic reticulum and the mitochondria. As you all know, those are organelles that are highly involved in the fertilization and early embryo development events. And they also observed a similar distribution in the meiotic spindle in oocytes that were vitrified using the conventional or the modified shortened protocol. Next. So how is this working in the clinical field in our labs? So this is a table, it's a busy table that summarizes some of the first studies. In this, we have only blastocysts. Most of the studies used blastocysts that were previously vitrified by using the conventional vitrification protocol, and then when were warmed using the one-step vitrification procedure. Most of these studies, half of them in this table, are abstracts presented to different meetings. But I just want to draw your attention that the survival comparing conventional versus one-step warming is pretty much comparable, very successful and high survival rates, and also comparable implantation, clinical pregnancy, and life birth rate. And here is the study published by Juergen in 2024, and they even observed a higher implantation and clinical pregnancy rate with the shortened protocol. Of course, I'm not going to stop on this study because this is Juergen is our next speaker, and he will explain it much better than me, of course. Next. Next. Thank you. So this is our study, which was recently published on RBM Online. This is available, so far is available online. And this is a proof of concept trial to test this one-step warming procedure using sibling donor oocytes. So it included 30 donors and recipients, in total 352 oocytes. And by the time those, very important, those were oocytes from our bank, so they were previously vitrified by using the conventional protocol. And by the time of warming, what we did was a randomization according to split the sample into two groups. For some cryotopes were warm using the conventional protocol, and some other cryotopes, according to the randomization list, of course, were warmed using the one-step procedure. Then we analyzed, after warming, we analyzed these oocytes with the Magenta AI tool. And then we proceed with the ICSI, of course, using the same semen sample, because all the oocytes, conventionally and one-step warmed oocytes, were donated to the same recipient. And then we were able to analyze fertilization, embryo development, and of course, clinical outcome. And this is on the right. You can see, as we explained before, the two warming, conventional and one-step warming procedures that we used. Next. This is just to show you baseline characteristics of donors and recipients. Next. And this is to show you the clinical outcome. No differences were observed in any of the parameters we studied, but for almost all the variables here, survival, usable blastocyst, good quality of the blastocyst, and clinical outcome, the results were a little higher in the one-step warming compared to the conventional warming, but no, these differences didn't reach the statistical significance. But we don't know, probably when we grow this our database, we are going to be able to find the statistical differences. So this is of course very reassuring. And actually next, it shows that this protocol is working very well. Here, we also, to further analyze the effect of the warming procedure, we conducted this logistic regression analysis for the ongoing pregnancy rate according to the warming procedure we used. And as you can see, but the first odds ratio underlined in pink here, this odds ratio shows that the warming procedure has nothing to do with the ongoing pregnancy rate. So the one-step warming do not alter the ongoing pregnancy rate. And in the table down, you can see the AI analysis, the magenta, both the magenta and the IDA score for all embryos of the usable embryos were comparable between conventional and one-step warming. Next. So our study shows that there are comparable survival, the fertilization, developmental competence, and clinical outcome between both strategies in donor oocytes. Next. But what's next? In our opinion, to test this procedure with autologous oocytes, because we know that with donors, everything works very well, but we need to test this in autologous oocytes, in blastocyst, and our next step would be to test the protocol, the combined shortened protocols, either for vitrification and for warming. Next. So I'm going to share with you some of these further evaluations that we've been conducting in our lab in Valencia. So this slide shows the results for autologous oocytes. We have compared conventional versus one-step warming And of course, all of these oocytes were previously vitrified using the conventional protocol. On the left, you can see the baseline characteristics of our patients in the conventional and one step. To underline, just when the patients return to warm their to use their oocytes, the age was older in the patients using the one-step warming procedure, and also that the progressive motility of the spermatozoa were higher, was best in the one-step group. On the right, you can see the IVF outcome. To underline, survival rate was statistically higher when we use the one-step warming versus the conventional, 91% versus 83%, and all the remaining parameters, fertilization, usable blastocyst, embryo quality, and clinical pregnancy were compared between both procedures. Next. As we did before, we wanted to further analyze the effect of the warming procedure in fertilization, usable blastocyst rate, and clinical pregnancy rate, showing no effect of the warming procedure with regards to fertilization and clinical pregnancy rate. But when we analyze the usable blastocyst rate, the odds ratio here shows better outcome when we use the one-step warming procedure. And there is also effect of the age in the usable blastocyst rate. And as I mentioned before, we had better progressive motility of the semen samples, and it was also related to the usable blastocyst rate. But I think this is very reassuring that this procedure, one-step warming dilution, is working very well also with autologous oocytes. Next, please. And the analysis included also PGT and non-PGT cycles. This is our experience with blastocyst. Here, all the population, PGT and non-PGT. Again, blastocysts that were previously vitrified using the conventional protocol and then warmed using the both conventional and one-step warming. No differences in survival, any of the parameters we studied. Implantation, clinical pregnancy rate, and ongoing pregnancy rate. And again, we also further analyzed by the logistic regression analysis. And to I want to draw your attention that again, the warming procedure was not related to the ongoing pregnancy rate. Next. Same thing happened with non-PGTA blastocyst. Here, the only thing that affected the ongoing pregnancy rate was the embryo quality, but not the warming procedure. Next. And this is quite the same picture for PGTA blastocyst. So this is working, as also the study by Juergen and some other studies in the literature shows that this works fine irrespectively of the biopsy status of the embryo. Next. And this is our last step, or our last population we wanted to analyze. This is again randomized study, and this time we wanted to analyze both fast. I don't like to use the term fast, but the shortened protocols for both vitrification and warming. It was conducted with oocytes, so donor oocytes. It included 20 donors and 20 recipients, in total 245 oocytes, as you can see on the left. What we did was using the same cohort that was going to be allocated to one recipient, we randomized the oocytes that were going to be vitrified conventionally or using the shortened protocol, just 1 minute in ES and 1 minute in vitrification, in BS solution. And then we did the ICSI with the same semen sample, and we repeated the same study design that I just showed you before. On the left, you have the results. Survival, implantation, and ongoing pregnancy rate is pretty much comparable. And also, again, with the odds ratio, here shows that there is no effect of the vitrification and warming procedure in the ongoing pregnancy rate. I think this is also very reassuring that we can start to apply the shortened protocols also for vitrification, and then proceed, of course, with the one-step warming dilution. I think this is my last slide. Next, please. Yes, of course. I want to thank all of you for your kind attention. Of course, my team in Valencia and my PhD students, Lucia Murria and Laura Conversar. Thank you very much.
Thank you so much, Anna, for this nice presentation. You presented to us not only your recent paper that was published in RBMO, but some really interesting unpublished data. And that's really fantastic. Thank you so much. Of course, there are a lot of questions for you, which we will get to at the end. But I wanted to ask you, I don't know if I got this correctly. The autologous oocyte trial that you did that is unpublished, is that also randomized, or was
No,
it
no,
just...
no. No, no,
Okay.
no. We just took as control the previous the warming procedures that took place between January and July 2025, and from July from July on, we did the warming procedure using the one-step dilution. So we compare like with older. We use control as a control the previous warming procedures that we did this year. So this is not randomized.
And did I understand correctly that you saw lower survival with the one step?
Yes. No. With the conventional. Statistical
With the
differences.
conventional.
Yeah,
Oh,
with the
right.
conventional.
Okay.
With the conventional procedure.
That's interesting. How
Yeah, it is, because
what
those
do you
are
think?
autologous oocytes, and we couldn't find the differences using donors. It's quite interesting, I know, but I'm confident that when we have some more data, we collect some more data with donors, then probably we will be seeing some statistical differences, not only in survival, I guess.
Right. Very interesting. And a very quick technical question. A lot of people are interested in knowing about protein supplementation post-warming of oocytes.
Yeah.
How do you supplement?
We are
culture
not, we
medium?
just use our regular media. We haven't changed anything.
All right. So
we
what
use
is the
the
protein?
Origio. We use the media from Origio, the fed from Origio. That's what we do. We go the oocytes go directly to this medium. Then we do the ICSI, and we don't
change.
We don't additionally supplement anything.
Okay.
Yeah.
All right. Thank you so much. We'll come back to your talk at the end. This was really enlightening. Thank you.
Thank you. Thank you.
So now I have the great pleasure of introducing our final speaker today, Dr. Juergen Liebermann. Of course, Juergen really doesn't need an introduction, but I will tell you that he has worked in IVF since 1995. He's the director of laboratory services at the Chicago-based Fertility Centers of Illinois, within the U.S. Fertility Ovation RMA New York network. He earned his doctorate from the Technical University Munich in 1995 and his postdoctoral qualification as a lecturer in experimental reproductive medicine at the University of Würzburg, I hope I didn't mess that pronunciation up, in 2004. He has delivered more than 160 presentations worldwide, published over 66 abstracts, papers, and book chapters, and co-authored the book Vitrification in Human-Assisted Reproduction in 2007 and 2016 with Dr. Michael Tucker. He's a member of ASRM, ISHRA, and ABB, and serves as an ad hoc reviewer for several leading journals in the field. It's my pleasure to invite Juergen to present his talk for us today. Thank you, Juergen.
Thank you very much, Mina, for his kind introduction. And the title for my talk will be Fast and Furious Life in the Fast Lane. Let's dive right into it. I want to bring up some facts here in the US and globally. 1 out of 6 couples struggle with infertility. If we look at the treatment cycles with cryopreservation involved, we see a clinical adoption of vitrification starting back in 2004 has profoundly changed our practice. It supported the implementation of selective single embryo transfers. It brought more freeze-all cycles, increase in fertility preservation cycles, supported routine implementation of pre-implantation genetic screening. And finally, when we look at the data published recently by ESHRE in Copenhagen, about 30% now, and this number is rising every year, and we talk about 12 million babies totally from IVF, so about 4 million now are offsprings born worldwide from IVF cycles where oocyte or embryo cryopreservation was involved. So we can conclude so far we have an increase in vitrification warming procedures. And I want to give you some examples from our daily work. And I picked here 5 days over the course of the year 2025. And I counted the total number of procedures when I counted the number of oocyte vitrification, the number of cases where biopsy is involved, and of course, consecutive freezing, and also the number of FETs we have on a daily basis. On the end, I come up here with 215 procedures, and 153 out of these procedures involved cryopreservation even of oocytes or embryos. And so when you bring this data to a graph, it's fair to say that about 40% of our daily workload involves vitrification warming of oocytes and embryos, 30% about biopsy of embryos, and then the remaining percentage is for ICSI transfer or oocyte retrieval. So, based on our workload, we see 60 to 75% of our daily procedures involving cryopreservation of oocytes or embryos. And so when we look back, for example, the entire year since September 2024 until October, we did so far 2,600 FETs. That brings us to 186 in average per month. And, our work is very complex, and it's sometimes complexity by design. And if you are not aware of, so I want to show you here how complex we are. So our vascular system has blood vessels. They are more than 95,000 kilometers long. Our nerve system has about 72 kilometers of nerves, and our human skeleton contains about 206 bones. And this is just an example of one of my team members. Drawing shows, how we set up different solutions, different dishes. And, you see, without taking much time, it is very complex. And there is now more and more studies. They face a problem of burnout. A lot of studies were looking into the experience of couples through their journey in IVF and how they solved and deal with stress. And now we get more and more couples. They focus on the professionals in assisted reproduction and how they experience stress and how they can deal with stress. So burnout is a very important topic. So to recap to this point, we have an increased number of treatment cycles with cryopreservation combined with genetic testing. We have an increase in complexity and workload demand. We see an increased workload underscores a critical need to streamline and simplification of our standard operation procedures to amplify operational efficiency, minimize steps to complete a procedure, and with that mitigates the risk of errors and burnout. All that without compromising clinical outcome. And what we know so far, and Mina mentioned that before, a stepwise removal of the cryoprotectant and rehydration was a fundamental principle in cryobiology, and we followed that for 30, 40 years. The theory behind this approach was to minimize the damage to the cells, and blastocyst oocyte vitrification warming protocols, if you work in this field, are very time-consuming and labor-intensive. So imagine we would have a protocol that gives us 100% survival using one single step during rehydration. And, as Mina mentioned, I give a lot of talks, and sometimes I like to remind us of the procedures from the past compared to today, especially for many young embryologists. And I made this table here just to show you, where we started in 92, and I used a protocol from Yves Menesso, who was very upfront on freezing blastocysts. And you see the protocol here involved many steps, and just the cooling time itself was 128 minutes, and the overall protocol took 148 minutes. When we introduced vitrification in about 2000, 2004, we dropped this time to an overall time of 11 minutes. And now, the standard protocol for us in our laboratory is a total of 5 minutes. And now I want to come to the frozen embryo transfers. The data I present here, I want to just clarify this. We used Irvine vitrification and warming kit. We use a closed system since 2006. It's called high security vitrification kit. And we use Sage blastocyst media for transfer with a supplementation of 20% SPS. The vitrification protocol. We expose the cells briefly for a brief rinse in 1 drop of ES. That's usually 7.5% of ethylene glycol and DMSO, so a total concentration of 15%. Then we put them in a second drop and let them there for 4 minutes. After 4 minutes, we expose them through 2 drops of vitrification solution for a total of 60 seconds. If you just as a reminder see the osmolarity, you see we're starting with the physiological osmolarity of 270 to 280. When you go in ES, and I mentioned that it's 15%, you reach an osmolarity of 2700. And when we finally go in the VS, that is a combination of ethylene glycol and DMSO, each of them 15%. That means we have a total concentration of 30%. We increase the osmolarity to more than 5600. And I don't want to reinvent the wheel, and as was mentioned before, I want to recognize the research and publications on one-step warming. And we have here some pioneers. Stanley Lieblow in 83 and 84, he demonstrated it on cows. William Rahl, who was one of the first publisher of vitrification protocols in 1985, with mouse embryos. Then Mitschieve here in 89 on sheeps, and Izumori and others on bovine. And finally, it's very important to mention this, a group around Mons and Thiel Taylor, who published that with prize paper as ASRM and at the PSCRS meeting in 21-22. And again, I want to bring, as I showed the time for vitrification, I want to show also the development in terms of warming. Again, I used Yves Menezos' warming protocol in 92, that was afterwards many times changed to even shorter times. What his standard protocol at the beginning took about 42 minutes. With the implementation of vitrification, we dropped that time to a total of 13.5 minutes. And now we are down to 1 minute overall. And you can imagine how much time we would save in each protocol and how that can improve our efficiency in our workflow. And so when I saw this data from Thiel Tyler and his group, I went home and I encourage everyone to do these validation studies. And we used embryos for research donated from patients. And after about 675 embryos, we decided to move on to implement this one-step warming in our clinical setting in September 22, September 22nd in 2022. And you see here, compared survival was very encouraging, perfect survival, excellent hatching rate. We kept these embryos 24 hours post-warming, just not to see how they survive, but also if they regain cell activity, and they demonstrated that in expansion, and of course they are hatching. So finally, we have here 2 papers on this. We published first our outcome in terms of pregnancy rates, and then when we had enough data, we also were able to provide live birth. So warming here, very simple now. We use a 400 microliter drop of TS. This is 1 molar sucrose at 37 degrees. And we plunge the embryos in the drop, keep it for 1 minute, and then we go in the transfer dish. This is the data so far. We did close to 6,000 transfers since we implemented it. And I just show you here's a positive beta per age group. And you see here under 35, close to 73%, 35 to 37, 71.3, and 38 to 40, 70%. Over 40 is a drop to 63%. When we look at day 5, day 6, we see, of course, a better outcome with day 5 embryos. This is true for tested as well for untested embryos. So protocol works very well also for embryos. They are zona-free, but can happen by the biopsy, or it can happen in culture, especially on day 6, when they hatch on their own. You see here also an excellent positive beta of 68%, and it works very well in gestational carriers where we achieve far beyond 74% positive beta. And this is the most important table here because it shows you a comparison between the traditional steps and multi-step warming that included multiple steps in sucrose to reduce the concentration of sucrose, and then compared to the one-step warming. And we can focus here on the live birth rate. You see here, so number of transfers or cycles here is very comparable, 24 to 2600. So the live birth rate was 51% in the one step, 48.5 in the multi-step warming. We looked at the live birth, the gestational age was comparable as well as the birth weight. And when we look at the gender between male and female babies, was also no difference between both groups. So equal outcome in terms of gestational age and birth weight in both protocols. So what will be the future bring us? And I want to summarize that to that point. In-house data provide evidence that 1 molar sucrose provides excellent survival, hatching rate after rapid warming of 1 minute, and excellent outcome data in terms of ongoing pregnancies and live birth. We also can show that lower sucrose concentration, such as 0.5 molar or 0.25 molar, works as well. If you have a medium with free allose or sucrose, it works equally effective. And after warming, the use of 20% or 10% purine supplementation works equally. A topic that will also be discussed in the near future will be direct rehydration, and this is also visible without using sucrose at all. Summary. The protocol presented here makes laboratory technique for warming blastocysts simpler and therefore contributes to the meaningful optimization of laboratory resources. It reduces the unnecessary time blastocysts are exposed to room temperature and in turn reduces the stress to the blastocysts. There is less time for radical oxygen species creation and their impact on the embryo development. Short dehydration, short rehydration is easy to implement in your daily routine and standardizes your blastocyst cryopreservation procedure and its outcome even more successful. It is safe, reliable, and significantly improves laboratory efficiency. It allows for more embryo transfers daily without creating additional stress nor compromises safety. Continue. As a more efficient procedure, it contributes to increased productivity by providing flexibility and optimized workflow. As I showed you, labor can be reduced to over 95%, and you also can reduce cost to about 40%. Embryology team feeling of improved quality of life at work, increased satisfaction of my team, which contributes obviously to patient satisfaction. Simplification from a multi-step to a single-step procedure, minimize repetitive steps. It's easier to learn to achieve proficiency faster. With the continued rise of art cycles involving freezing and shortage of proficient and competitive staff, this protocol has an impact by expanding existing laboratory capacities and reduces workload. The protocol helps reducing patients' waiting time, which contributes to patient satisfaction. I would like to thank you, my team, that has a huge contribution to implementing this protocol and to its success. And I finally like to thank everyone who attended these sessions. Thank you very much.
Thank you very much, dear Juergen. This is fascinating data, and thank you for sharing this interesting data with us. I'm sure there will be a lot of questions afterwards. So just a quick question. It is amazing to see the survival rate. I mean, you have presented in your data that out of 6,000 blastocysts, only 8 of them did not survive. So this is amazing.
Correct.
So do you have any clue which type of blastocysts would most likely not survive with this new warming protocol?
So, it is very important, and it was important before, regardless what protocol we would implement to freeze or thaw. You need a blastocyst scoring system, and you have to be consistent, right? It's very important what you freeze, and you have to freeze good quality blastocysts. If you have a deviation from your protocol for whatever reason, you will compromise your outcome. So in our hands, the embryos we freeze do very well. If we get embryos from the outside, they do very well too, but we see here more cases with less survival. And I'm speaking of embryos based on David Gardner's score, like 3B, B minus or 3C, B minus embryos, they will have an issue. But embryos, is it 4AA, 5AA, 6, even the sonar-free embryos, if they are a high score, they have no problem to survive this protocol.
Okay, thank you very much. So I believe it's now time for the panel discussion. I'd like to thank to all speakers for their excellent lectures. And Mina, how would you like to proceed for the panel discussion?
Yes, so we have a lot of questions and a lot of good
Exactly.
questions.
Yeah.
Maybe we'll start with a technical question that maybe Lodo could answer. And let me invite both Lodo and Anna to open their mics and cameras so we can have this discussion. Thank you. So this is just a quick technical question from Claudia Yvette Gambor. She's asking, do you have any experience reducing reagent volumes, for example, using Kitazato from 4 mil down to 1 mil? And I think this is generally maybe this is a specific question, but generally, because we have emphasized so much the volume of the thaw solution, wanting to have the fastest possible rate of warming and keeping that solution at 37 degrees. I think this question is important and relevant. So how would you answer that, Lodo?
Yeah, we commented this also in our article, in the discussion section of our article, because the fact that we tested 0.5, for example, in this case was with sage. But if you can perceive my idea, so for me, any brand is equal of the other. So we tested 0.5 sage and 4 milliliter of sage, and we obtained the same results. But we suggested in our discussion that so the volume is very important. There is also another question by Kimball Pomeroy asking me if this is relevant. In our study, we used 3 different carriers. So to make it more universal, okay? This means that if you have more volume, for sure you are more protected. So the temperature is more stable. But there are many embryologists saying, okay, I'm using 1 milliliter, 2 milliliter of Kitazato. We all know that Kitazato is suggesting 4 milliliters, okay? And then the same, solution, you may say, because the new kit in Irvine, I'm sorry, I'm making names, but this is what I think what the embryologists would like to know. So Irvine has the same, non-permeating solutes, 3 allels now, and they are suggesting 1 milliliter. So it's strange, okay? So we need to, that's the reason why, since we are not stupid, we need to define our standard operative procedures for our lab. So as Juergen said, make tests in our lab and write in our standard operative procedures of the lab, which is the volume that we are choosing and why. So if I could suggest anybody, I would always suggest to use large volumes because this is very protective for us. We avoid fluctuation of the temperature that we can have in the worktop. But there is also a withdrawn, when you are working with oocytes, having small volume, it helps you to find easily the oocytes. So you need to find the right balance. But I think that it's manageable. Many customers are using 1 or 2 milliliters of any kit. So in my mind, all the kits are comparable. So Kitazato, Irvine, Sage is the same.
Thank you. Yeah,
Thank you. Another very interesting question that was addressed to Lodo by Mirela Sina is artificial shrinking of the blastocyst before vitrification recommended, and what are the advantages or disadvantages of this procedure?
Okay, so probably also Juergen is able to answer better to this question. In my lab, I never intentionally shrink the blastocysts, but nowadays 80% of these blastocysts are undergoing to biopsy, so they are shrinked. Okay, so I don't know. Until 4 or 5 years ago, we were not shrinking the blastocysts, and we always had the same consistent results with any kit by using large volumes and by combining the different kits, but using the open carrier. So probably Juergen can add
Juergen,
something about
would you
this.
like to comment on that too?
Yeah. So we do 90% biopsy, and there is obviously no shrinkage required. And there was a question also in the chat, should we put these embryos back in the incubator, wait for re-expansion? So we have a very different approach. We biopsy, and we have a team ready of embryologists, and the blastocysts will be vitrified 5 minutes later. So they will be right after biopsy vitrified. So there is no hatching necessary. For embryos, and we still have cases, we do fresh transfers or no biopsy, we will collapse them. And I think now where we shorten this time of exposure, it is definitely beneficial and helpful for the blastocysts to get sufficient dehydrated by doing this collapsing.
Yeah, that's.
So may I, sorry?
Oh, yes, of course.
Yeah, if I understand clear what Juergen just said, so for the shortened protocol for vitrification of blastocyst, you are doing the artificial collapsing. Is that it?
Yes.
Okay. So it's
every embryo who was not biopsied will be collapsed.
No need for the conventional protocol, but for the shortened protocol, you are.
Yeah, so we collapse since 2009. And, we published that. I had a paper with Joe Conaghan, and we saw a benefit by, there's not a big trauma. This is one laser shot to a junction of trophectoderm cells. It takes like 10, 15 seconds. Your blastocyst is collapsing. You see releasing of the water from the blastocyst. And I think that is supporting and allows us a short exposure time where we're all interested in to expose these cells as much as possible, less possible to with cryoprotectant, but as much as we need. And so we have to, I think we can do something to achieve both short exposure time, but also making sure they have a sufficient dehydration to guarantee vitrification inside the cell.
Okay, thank you.
Yes, but also Anna, keep in mind that Juergen is using the closed system, HSB.
Okay.
That's correct.
So, Anna, if I could read this question to you, which is an interesting practical question from Estrella Rosenberg. She's asking, what would be your suggestion for thawing one oocyte that was frozen with slow freezing 19 years ago?
I would proceed with the warming procedure for vitrification.
And the short end, the conventional?
That's a good question.
It's a trick question.
I mean, yeah, it is, because now, I mean, and this is just a practical issue. There is no availability, at least here in Spain, of the regular warming kits, at least for Kitasato. So we are now buying all the new kits for the one-step warming. So that could be one reason for, and we cannot use home-made media. So probably we are obliged to do the one-step warming. But a part of this, I think that probably it's going to work the same if we do the conventional or the one-step warming with this slowly frozen oocyte. I don't know. I don't know my colleagues, Juergen or Lodo.
Lodo.
Yes.
Yeah, I would say 1 molar sucrose, it's enough for everything you need to warm. So, you know, when you have this in your hands and you have done this for 20 years, you understand that this is the way. Of course, we have experience in warming oocytes and blastocysts that were slow frozen with a warming protocol, 1 molar sucrose or trehalose. And now, so taking out some steps, it is not. It is just simplifying the procedure. It is not something that it's affecting the survival.
There's a question from Jeff Bolt about the first two talks. He's saying that I'm curious if any kind of power analyses were used for some of the studies shown in the first two presentations. There were some data points that did not show significance, but percentages varied by a fair amount, perhaps due to the low sample sizes.
Yeah, no,
And he adds
sorry.
that he applauds the work.
Yeah. In our case, it was a proof of concept study. So we wanted
Yes,
to
you did
test
mention.
if this protocol was working. So that's why we don't have any power calculation.
Okay.
Another
And
very,
Lodo?
yeah. Sorry.
And I think, Lodo, do you have a comment on your study?
Well, you know, when you do a course study, so doing it was a course study. The first study, both studies are course studies. So power analysis, I don't know. Of course, the second study was made in a small number. And that's the reason why we are continuing to do this for the single step. And now we also have vitrification, short vitrification, single step. I would like to give my feelings to everybody. We all experienced this process of vitrification in 20 years. When you start to work in this way, it is very difficult to go back. You know, in the lab, everything is very smooth. The survival is the same. Probably big group such as the group of Anna will demonstrate very soon that also survival for oocytes will be improved, because I got this feeling. I got this feeling with the small data that I have, but it is something that you understand. It's 20 years that we are doing vitrification, so I'm pretty sure. I'm sorry, it's the first time that I'm so convinced, but I think the majority of my colleagues that are doing this, they are perceiving what we are doing now.
Another very interesting question by Amir Araf. It was addressed to Anna, but I think it would be nice to hear the comments of all the speakers. Do you think that the short protocol will make automatic vitrification more possible?
That's a very good question. And well, I think now for those companies that are about to have commercially available devices, I think the shortened protocols are a problem for these companies. because they will need to, to rethink and rebuild everything. But I don't think it's going to be a problem. It's just a matter of time that they need to adjust. I really don't think there's a problem in it. I don't think so. I don't know.
Would anyone else
My
like
colleagues?
to comment?
I would like to
I don't
comment
think
that. Juergen, go.
I don't think the protocols we now evaluate, and with every more publication, we feel more secured. It's the right direction. Has an impact on automatic vitrification. Automatic is out there now for 10 years. It never took off, and with even now the protocol even simpler, I'm not sure where I should find a benefit applying automatic vitrification. I had some devices in my hands and they work, but I think it needs more experience to work with them in these really timely manner, short protocols, than do it as an embryologist. So I'm not sure. I don't really see a space for automatic vitrification at this point, that it will be implemented. When we talk about in general, and we think about the company conceivable where automatic vitrification will be a part because everything will be automatic. I think it will be realistic, but maybe 10, 15 years from now. The outcome of oocytes and embryos freezing, warming will be not affected. I think we are now at a very high level in terms not just survival, but also securing competence of these oocytes and embryos of the exposure of low temperature to the highest degree. I don't think we will change that with implementing automatic vitrification.
If I could just make an observation or a comment, when I think about this, and this is a very good question, the way I think about it is that anything that removes nuance, that requires human judgment, would facilitate automation. If you have to, you're looking, we train our embryologists to look at the membrane while the cell is in solution X, and when it appears like in a certain way, then they can move it to the next solution. These are nuances that would be lost on a robot. So, I think that is the key, that if you remove those nuances and you say every single case you do the same thing, and you don't look at, you say 1 minute, and 1 minute is 1 minute. It's not maybe 1 minute, maybe 5 minutes, maybe 10 minutes. So that should lead to easier ways to automate the process. But like you say, Juergen, I think it's complex.
Yeah, I have a good example, Mina. When we started vitrification 20 years ago, we had different drops, and we combined the drops. And by combining and observing, the shrinkage and re-expansion of blastocysts, we made a decision to connect to the next drop to increase the concentration of the ES solution. And we did the same when we went through warming. And just by stopping this and using one drop and put the embryo oocyte in one drop and let just everything work by itself, improved already outcome, right? Yeah. So because before we had these nuances, as you mentioned, it was very different from embryologist to embryologist to make a decision. Is the embryo now ready to move on to the next concentration, right? Is now the degree of expansion achieved that we can shrink it again to get more water out? That was so much user depending, and we did that for a long time. until we went to drops and time. So we took the decision of the embryologist out of this equation, and when we saw more consistency, that comes down also to survival and outcome.
Yeah, very good points. I wanted to ask a general question. So, for people who have not yet switched to the shorter, faster protocols, how do you suggest they go about switching, or at least assessing how the protocol works in their hands? Because it is scary, and it's also the question of this question has come up before, whether such modifications in protocols require approval from an IRB, for instance, or specific a specific consent from patients. So what are your opinions? I'd love to hear that.
So
Maybe starting with Anna, sure.
Yeah, I would suggest at first, if you do donors, then start with the last cryotop or the last device with the one-step warming with the new modified protocol. If you don't do a lot of donors, then what we do is to ask the permission, as you just said, to the patients to use their spare oocytes, those GV oocytes, or those oocytes that we don't use, and allow them to in vitro maturation, and then use them to test the protocol. I think that's the only way, because and that thing first, and then go with the last cryotop, the last device. Let's not say cryotop specifically, but the last device of a patient or a donor who has, let's say, four devices. Then start with the last one, and just try. Better do it with donors, of course. And that would be my suggestion. But in our case, the learning curve was not so dramatic, not really. If you are trained in the conventional protocols, there is no drama in switching to the modified protocol.
Thank you so much. Juergen, do you have any comments on that?
Yeah, first of all, I mean, we have the publication by Anna on oocytes and Lodo, and we have blastocysts, not just from me, there's other groups out there. So, having this available now should be the first step to, think about, right? It gives you already some confidence, right? Then you have to find your own setup. You have to have your consent form for, that people discard the oocytes, whatever you have in their treatment plan, research to donate to research, and so. And then you should find ways to use that material that is not to your patient's use, and start there. But based on what we have already out there, should be a good starting point. It's not that you just do something that was never done before. But you should one day open up yourself and overcome old protocols, old thinking, and open up yourself to new ways to explore.
Yeah, and I think it is important to point out, if you have a long-standing approval from a review board saying that you can try modification of protocols in order to improve outcomes, that trying these new protocols would not necessarily require additional approvals and special consents, because what we do is we we change culture media, we change supplementation, we do all sorts of things without going to the patient specifically for consent, because it's just part of the process. But if you decide to run a trial and you say that you are running a trial to compare one method with the other, then I think it's logical that you would have to obtain review board approval and even going with patient consent. So that was an editorial comment, because this issue has come up before and has been discussed, as you know.
Yeah. Yeah, and you know, I think it comes down to us as lab director. You know, we have the experience, we have the expertise. There must be some space for us to explore this, and especially something we developed 20 years ago. We know it works. I just thought today overall 25x were slow frozen, so traditional way, traditional vitrified. And you know, I use the same way. Of course, it's like this 1 minute, 3 minutes, 5 minutes. It takes long, and they all survive. So we know it works. But so we get to that point, how we can make them even more efficient, because when we have an increased number of egg preservation, and we see that every day, it is time to think about. It's not that we were not at a point it didn't work. It worked very well. And based with that, we can now move on and explore new fields to make it even more efficient in terms of the time. And when we reduce the time and exposure time, I think we even help oocytes to do better after warming, and that is true for embryos as well.
Thank you so much. This has been a great discussion. It's very late for many of you, and so I think we will bring the session to a close. I'd like to thank all of you who joined today's RBMO live session. My truly sincere thanks to my co-host, Dr. Başak Balaban, and to our wonderful speakers, Lodovico Parmegiani, Anna Cobo, and Juergen Liebermann. I'm very glad that you accepted this invitation. I'm very glad that you submitted your papers to RBMO, and very happy to see your work published in RBMO. It's been an informative and enlightening session. I'd like to also thank and recognize the I3 organizing committee, Jacques Cohen, Peter Nash, Marianne Savetes, Thomas Elliott, Francesca Farley, Violetta Sora, and Giles Palmer, of course. Join us again next year, although I'm not sure if this is the final session of this year. I'm not sure, but don't miss next week's last of the year celebration. Here we go, with a webinar entitled Repet, all about animal physiology and cloning. See you soon. Thank you. Bye-bye.
Bye-bye.
Thank you.
Bye.
Thank you.